Hey, Dr. G, can you repeat that for me, please? Let's begin.
Jesus fucking Christ, are your ears as fucked as your occlusion? Fine. What's the first goddamn step in the preoperative workup for skeletal class 3 malocclusion headed to orthosurgery? Don't make me shove a cephaloscope up there. Answer.
All right. A little fire this morning, huh, Dr. G? Okay, so the first step in preoperative workup for class 3 malocclusion. So class 3 malocclusion is when you have a prognathic mandible. So I'd want to get clinical photos, extraoral photos. I like to get a CBCT scan, panoramic scan. I'd like to get some models. I'll take some impressions to make up some stone models for the workup. I would like to take a scan of the dentition as well, an intraoral scanner. I would also like to go through all the preoperative questions. So, previous medical history, allergies, medications, previous surgical history, any history being under anesthesia. I'd like to get to know the contact. I'd like to get the contact of the patient's orthodontist so that we could plan this case together. We'd have to VSP it with one of the teams, whether it be, I'm not going to mention the company names, but we'd have to VSP this virtual surgical planning. We'd have to make sure that the occlusion is right, that the final casts fit together well. Let's see. I'd also like to measure the midlines. I'd like to get the cephalometric analysis. Yeah, okay. What did I miss?
Look at Mr. High and Mighty rattling off every damn imaging modality like he's ordering fucking Starbucks. CBCT this, panoramic that, VSP bullshit, yet you still goddamn
Preoperative labs, definitely preoperative labs as well. I forgot to mention that.
Preoperative labs? Sweetheart, you're about as sharp as a goddamn tongue depressor. No, shut your pie hole. The first step, the very first, is a detailed clinical examination. Frontal, profile, occlusal views, mobility, periodontal probing, airway assessment. Did your mama drop you on your fucking skull instead of teaching priorities? After that, then you think about x-rays, models, cephs, labs. That's down the road after you've actually figured out if the patient's a walking lawsuit. Christ, you want to cut faces but can't even sequence your own goddamn workup. Next, what's the most common cephalometric finding in skeletal class 3? Angle, width, or Steiner? And if you say prognathic mandible again, I'm going to ram a model base up your, just answer correctly.
Most common cephalometric finding? I'm not sure what answer you're looking for here. Let's go through it.
Not sure? That's rich, because the answer's a goddamn billboard. Angle cephalometric measurement showing a skeletal base relationship of maxilla to mandibular greater than 0, meaning your maxilla is rearranged, not the mandible jutting like some caveman's prom date. You thought class 3 was just mandibular prognathism? Huh, more like retrographic maxilla half the time, Einstein. Grow a brain or I'll staple your fucking diplopia shut. Now, name the 2 classic surgical options for fixing a true skeletal class 3 with normal overjet. And don't give me orthodontics, or I'll shove a BSSO plate down your throat.
2 surgical options for fixing a true skeletal class 3 would be either the Lefort maxillary advancement or the mandibular reset, bringing it back.
Lefort? Mandibular reset? Jesus, tap dancing Christ? Do you even read the goddamn atlas? Or just jerk off to pretty pictures of jaws? It's Lefort eye maxillary advancement bingo. And bilateral sagittal split osteotomy. With setback. You illiterate fuckwit. Setback. Like setting back your birthday by 9 months so your mama could have had a better shot at raising a half-decent surgeon. Lefort eye advancement fixes the retrograthia. BSSO setback fixes the prognathism. You know the drill. Maxilla forward or mandible back. Pick one. Or hell, do both if you're fancy, and the patient's face looks like a Picasso done by a drunk toddler. If you ever confuse reset with setback again, I'll reset your face into the goddamn pavement. Now, what's the single biggest complication of BSSO setback, and how the fuck do you prevent it?
One of the biggest complications with a setback is, well, technically it's the advancement of the mandible that's more stable than a setback. One of the biggest complications or adverse events after a setback is relapse, right? So the muscle pull is going to be pulling the jaw back towards its initial position, but the plates are holding it in place. What word did I just? Yeah, relapse, yeah.
Relapse? Relapse? Are you brain dead or just allergic to the actual answer? The single biggest complication of BSSO setback is temporal mandibular joint disc displacement, you drooling moron, followed by fucking neurovascular injury to the IAN. Relapse happens, sure, but that's not the goddamn intraoperative apocalypse you're supposed to scream about at boards. You prevent it by perfecting your split technique. No saws jamming like your ex's excuses. Use piozos. Protect the nerve. And fix the disc if it's already halfway out its socket. Jesus, if you can't protect a nerve, you're going to end up like half the idiots in private practice, suing for malpractice over numb lips. Next, what airway structure do you always check before moving a Class 3's maxilla forward? And don't say nose, dipshit.
Thyromental distance?
Distance? That's what you say when you're intubating a fat fuck, not when you're sliding a maxilla 6 millimeters. You always check the nasopharynx for adequate velum length and no hypertrophied tonsils, because advancing a retromaxilla can drop your patient's airway like a drunk chick's inhibitions. Imagine waking up from anesthesia with a collapsed velum, no CPAP, no mouth guard, just a goddamn choking disaster. You want to kill people? Keep guessing like a magic 8-ball. Next, what 3 things do you do immediately if you nick the pterygomaxillary junction during a Lefort eye and the pterygoids start bleeding like a stuck...
First you would hold gauze compression, but when you hit the intermaxillary artery, which is probably what you hit there, that you're probably going to have to go to IR and embolize.
Gauze compression? For a hemorrhaging pterygomandibular juncture? Are you trying to write death by exsanguination on the consent form? You absolute cocksucker? No. 3 things. 1. Digital fucking pressure with your goddamn thumb right on the bleed site while your circulator grabs suction. 2. Inject neat lidocaine with epi around it to buy 30 fucking seconds. 3. Crack open the anterolateral maxillary wall with a chisel or kerosene. If that doesn't tamponade it, then yeah, pack it with hemostatic gauze like your life's worth something, and call vascular or IR if it keeps spurting like your daddy's alimony checks. Internal maxillary artery? Sure, could be, but don't stand there guessing. Pack it and move. You're gonna bleed someone out faster than I can curse your name. Next question. What's the king of all orthognathic stability studies? Don't say me.
That's a great question. What is it?
You think this is a game show? What is it? It's the prospective cohort study by Proffit Turvey from 95 to 200. Goddamn cases. 10-year follow-up showing BSSO setback relapses 3 to 4 millimeters if you don't rigid fix and do proper muscle adaptation. If you don't know that, you're going to end up like every resident who thinks stability means it'll be fine. Next, what's the one instrument you'd grab if your Lefort cuts drift superior and suddenly you're staring at a cranial base hemorrhage? And don't say screwdriver. I swear to God.
One instrument I grab if my Lefort cuts drift superior and suddenly staring at a cranial base hemorrhage? Okay, that's way too far back, and that resident should not be a surgeon at all whatsoever.
In God, yes. Finally, an honest answer. That resident should not be a surgeon. You're damn right. You should have said tamponade with bone wax and call neurosurgery while you kiss your license goodbye. But hey, you knew it was too superior. So maybe, just maybe, you ain't a total lost cause. If you're that far back, you're in the middle cranial fossa, staring at dura like it's your ex-wife's lawyer. You pack, you clamp, you don't move a millimeter, or you'll blow out the jugular foramen and watch blood fountain like Old Faithful. Next, and don't fuck this up. Classify the vertical dimension problem in a long-face class 3 patient who's going to get Lefort advancement. Is it dental extrusion, skeletal hyperplasia, or just looks like a horse, you pinhead?
The vertical dimension problem in a long face class 3 patient who's going to get Lefort advancement. Is it dental extrusion, skeletal hyperplasia, or just looks like a horse? Dental extrusion.
Looks like a horse? Jesus, I love it when you accidentally say something smart. But no, it's skeletal hyperplasia of the posterior maxilla. You half-right bastard. Extrusion? That's what happens when a lazy dentist lets molars drop like your IQ. Hyperplasia is when the bone itself grew like a weed because mom ate too much folic acid or whatever. Lefort advancement, counterclockwise, rotates that shit upward and backward.
Was your question, I thought you said your question was what problem can occur due to it, and there can be dental issues, or was your question actually what skeletal problem does that Lefort solve? What was your question?
Fuck's sake, Brendan. I asked what type of vertical excess you see in a long face, class 3, dental, or skeletal. Okay. And your dumbass said dental extrusion when it's skeletal hyperplasia. Period. Yeah, teeth might be long too, but boards want skeletal, because that's what you resect. You don't crown the whole goddamn mandible. Next, what muscle always screws you over after a BSSO setback, causing relapse if you don't slack it properly? And if you say masseter, I'm gonna laugh until I piss myself.
Well, I mean, you have the masseter, you have the malohyoid, you have the suprahyoid muscles, strap muscles, digastrics. It could be those. It could be the pterygoid. That would be That would be the medial pterygoid pulling onto the mandible. What did I miss?
Jesus, Brendan. It's like you're naming every muscle south of the ear just to hear yourself talk. The muscle that always fucks you is the suprahyoid complex, you blithering idiot. The genioglossus, geniohyoid, digastric. They yank that jaw forward like a goddamn bungee cord if you don't do a genioglossus advancement or slack them with genioplasty. Medial pterygoid, that's for sideways shit, not relapse dipshit. You forget the suprahyoids and your setback springs forward faster than your dick on prom night. Rigid fixation plus myotomy, or you're screwed. Next, name the 2 most common signs of impending airway obstruction post-maxillary advancement. And if you say snoring, I'm going to shove a Malampati IV down your throat.
Where is this question from, by the way?
You want to know where these questions come from? From the textbook you swore you'd read, Oral Board Review for Oral and Maxillofacial Surgery. The one sitting on your shelf, gathering dust like your fucking testicles. Median Finlay stuffed it full of high-yield shit like this.
Thank you. What's the answer? What's the answer? You said 2 signs of impending airway collapse after a maxillary advancement. What's the answer to that?
Listen up, fuck nugget. The 2 signs are increasing negative pressure snoring and paradoxical abdominal breathing, meaning their belly moves in while they try to suck air like a goddamn drowning dog. You see that in PACU, you slap on NIP-B or reintubate before they turn blue and blame you for turning a class 3 into a class autopsy. Christ, I spoon-fed you. Now quit asking me for answers like I'm your mommy. Next, in a Lefort 1,
excellent.
what exact millimeter rule?
Time to head into work. Here we go.